Good afternoon, everyone. Thank you for joining. We're going to hold on for about 1 or 2 minutes just to let the rest of our group join in. So thanks for being patient, and we'll get started shortly. And as a few more folks get in, just to let you know, we're going to wait about 1 more minute to let some folks get in, and then we will get started. Thanks for joining us today. Well, I think that we are going to go ahead and get started. I'd like to thank everybody for joining us this afternoon. We're here to discuss closing the access and outcomes gaps in mental health care. My name is Jeffrey Green. I'm the Vice President of Health Plan Development for Headspace Health. We've got several timely topics that we're going to cover today. First, and really on the sort of the front of everybody's mind, is we're going to talk about the access gaps that exist within the mental health care system today. We're also going to talk about the importance of proactive navigation of members to the right level of care. It's something that's very timely. We're also going to talk about the importance of value-based care in healthcare, in mental health care delivery. And then we're going to wrap up with how health plans are seeing better mental health outcomes and engagement without necessarily increasing cost. Just some housekeeping for today. There is a Q&A at the bottom of the Zoom. We encourage you to use that throughout the call. My guests today are going to do some prepared responses and conversation for you, but then I'll come back a little bit later and I'll start to pose some of the questions that were put in the Q&A for them to answer. So without further ado, I'd like to introduce Mary Lankowski, the CEO of Solera Health, and Russell Glass, CEO of Headspace Health. Mary, I'm going to turn this to you and let you introduce yourself to the team.
Great. Thank you, Jeff. Thanks, Russ, for joining me here. Very excited to talk about this important topic today, and I'm always excited to talk to Russ, our friend and business partner. So I think you'll observe that Russ and I will probably be fairly conversational and informal. And we'll start just with a quick intro of our respective companies. So I'm Mary Lankowski. I'm CEO of Solera Health. What Solera does is we play an important role in the healthcare system. We work with payers and employers. We are technology infrastructure that allows a payer or employer to have a single point of contracting and IT integration in order to provide a bunch of different condition programs. Solera curates networks of point solution providers, both community-based and digital point solution providers. And we'll talk a little bit about how we do that, because it's very important curation that takes place. We pick our partners really deliberate about looking at the entire market and looking at who is doing a really good job clinically, who's driving outcomes, who's willing to be on a value-based payment infrastructure, and who can put their money where their mouth is, so to speak. Who's really effective at engagement and a number of other factors. And so we're really selective in how we pick our partners. And of course, that's how we got to Headspace after looking at the entire mental health and behavioral marketplace. We match members to their best, consumers and members to their best fit solution. So this is a really important part of what Solera does that makes us special and unique, but that really drives superior outcomes. And we're going to talk a little bit about this matching today, because when we match members to their best fit, whether that be based on acuity level or learning style, whether they need a structured or unstructured program to participate in, when we match them to their best fit solution, we save money and we drive better outcomes. They're more motivated to engage and they have a better fit for the program. So we'll talk a little bit about how we do that in the mental health space, as well as payment. We pay on a value-based payment infrastructure. This is a really important part of what Solera does, because we believe in paying only for performance and outcomes. And so our goal here as a company is to work with this digital and community-based ecosystem and make all of this a really workable part of the healthcare system, make this really legit sites of care that drive total cost of care savings and real clinical outcomes. And so when we got to partnering with Headspace, I started with the question of, can we do all the stuff we do in the mental health space? Can we do value-based payment in the mental health space? Can we expect performance and outcomes? Can we curate and match in the same way? And we sat down and we partnered with Russ and Headspace to really figure that out together. And what we'll talk you through today is it totally works. You can absolutely do value-based care when it comes to mental health. You can expect outcomes. And it's actually, in some cases, even more imperative in the mental health space to get somebody matched to their best fit solution than even in other condition categories. So Russ, with that, I'll let you introduce yourself, and then we can talk about how it all works together.
Sounds great. Thanks, Mary. Very excited to be here today for a couple of reasons, which I'll get into. First, CEO of Headspace Health. Our company is trying to transform the mental health industry to improve the health and happiness of the world. We have brought together a world top 100 brand and experience in Headspace with a step care model that guides people between behavioral health coaching, therapy, and psychiatry. And we've brought that together in a way that enables us to really help people understand where they need to be. Most people, show up and really don't know where they should be in the mental health system. They just know they're not feeling great. We have built a platform to help them understand, and with a wonderful experience, consumer and member experience, get them to the right place, maximize the use of licensure that we're putting people in front of, and deliver outcomes. And excited about this partnership for a few reasons, and talking about this for a few reasons. One is, every time I go to any conference or any event, when Mary and I sit down, we have amazing conversations about each other, about the space and healthcare and where everything needs to go. And so it's going to be fun, I think, just to talk about this and share some of these fun conversations we have. But the second is, when we came together to build this partnership, I think we both took some of these learnings about the healthcare space and what we're trying to accomplish, and said, okay, well, how would we design a partnership to actually go after solving those problems, to actually figure out, how do we solve the access gap in mental health care? How do we reduce costs and scale the ability to deliver care? How do we offer real-time access to the support that people need? How do we, do this in a value-based way? And that design philosophy came together with this partnership, and Blue Shield of California was an important part of this also. And we all said, okay, let's design something that is kind of how the world should work, right? How this should work out there in the broader industry. And so I'm really excited to talk about what we learned over the last 12 months, because when we designed it this way, it's actually working, as Mary said, and we're actually seeing tens of thousands of people come through this, and we're seeing outcomes, and we're seeing some just incredible insights that I think, if we could apply to the rest of the world, if we could get everybody understanding this and thinking about this, we really could solve the mental health problem at scale. And so it's just it's so tied to the mission, it's so tied to what we're trying to do, that it's a very exciting conversation. So thanks for doing this, Mary, and excited to kick off the conversation.
I love it. I thought I'd just share with folks, because a lot of people don't realize what it is we're doing together and how it works. So I thought I'd walk you through, just as kind of foundation setting, what it means when you enter into the Solera and Headspace mental health program. And Russ, you said something in the beginning when you were introducing yourself about how important it is to help somebody have platforms that help somebody navigate through, because they don't know what they need. And so really, that is such an important and critical piece that we found the impact cannot be overestimated, because you've got somebody who may be having anxiety issues, symptoms of depression, both in some cases, or extreme perceived levels of stress. And in the normal healthcare system, we take that person and we say, okay, what do you need? And they got to figure it out themselves. And it's incredibly overwhelming. And then there's capacity issues, access issues, coverage issues, stigma, all of the things that make it feel particularly impossible for the person in that moment of their life when they need help the most.
Yeah. You know,
Yeah.
I always wondered, about, by the time someone actually gets assessed and we're measuring their PHQ or GAD, how much worse is it than when they first started to try to navigate the system, right? Like, how much worse is just the giant pain of navigating the mental health system? What is that actually doing to someone's mental health? It would be an interesting study in and of itself.
It would, and it's why it's so imperative that we go as far upstream as we do, and why acuity level matters so much. And so I think the average consumer, a lot of times the average person who works for a payer, they think of the mental health model being a traditional, medication and or therapy based model. And what we're doing together is so interesting because we're catching people, they may have worked at it and failed for a long time and may have moderate, severe symptoms when they come to us, or they may be earlier on that spectrum, and we're catching them and able to put them in a mindfulness program. And so it's really important that what we do with that consumer, we set up a really easy, elegant, easy to use, convenient set of questions that helps navigate the person through and to what they need. And so we ask them some very simple questions about their perceived stress levels, the big buckets of anxiety and depression. We ask them if they've seen a therapist before in a traditional brick and mortar setting. We ask them about their symptoms. We ask them if they would be, we ask things that indicate whether they'd be better off in a structured or unstructured environment. And these simple questions, which they can answer in an easy, convenient way that is easy to navigate, that gives us together such a clinically rigorous look at what that person needs. And then exactly what to do with them. Should I put them in a mindfulness program or put them into cognitive behavior therapy? And in some cases, if necessary, there's emergency escalation that happens. We don't inappropriately treat these people. And so what we found together is when we take them through that program and match them to the right place, you end up doing a couple things. One, avoiding putting people in programs that really don't need programs, because sometimes you've got motivated digital users who just want to test stuff out. And we don't have enough mental health capacity to have people who don't need it, right, in programs. We identify those people who have mild, moderate, severe symptoms, and we get them to the right place, which preserves capacity and access over time because we're getting them to the right place. And we know it works. So that's how the program works. We take them through that kind of very easy set of consumer questions. And if any of you are listening to this thinking like, how many questions do you ask and do they actually go through that funnel? With Blue Shield of California, we asked 16 questions and 96% of people finished all 16. So it's very, very easy to use. And that's what gets somebody into a program.
Yeah. So a few things happen there, right? One, as I mentioned, this consumer experience, this navigation to where someone should be is easy and straightforward. So 16 questions, the vast majority of people complete it. But what we're seeing from there then is an optimization of the care resources that are being applied. So the first thing is, in the first month, we saw about 15,000 enrollments. Yeah. And part of that is just the value of that experience, the value of a simple, straightforward approach. There's certainly some brand recognition. The Headspace brand is something that people, I think understand and feel excited to participate in. but you have this significant number of members coming through, which in a traditional setting would swamp a set of therapists that don't have any availability as it is. And what we're seeing here is 80% of members that are coming through this pipeline are actually being navigated to self-care. They're actually being assessed, and we're seeing that we can manage that need with a set of self-care, whether it's mindfulness, meditation, it's prevention, right? So we're recognizing that someone is facing some stress, they might be facing some mild anxiety or depression, but we can send them into a program that is highly effective without needing to take resources that can be used for people who are more acute. So 80% go that direction. Of the remainder, we're then seeing that 80%, so now 80% of the 20% are being sent into behavioral health coaching. So a subclinical level of care, much more available, much lower cost than your licensed therapist and psychiatrist, but incredibly effective. 80% of members with moderate to severe depression had improved symptoms. 76% of members with moderate to severe anxiety had improved symptoms, and 80% of those that needed some live care going into that coaching modality. So you're seeing, again, a optimization where only 4% of the overall total of members coming through are needing to be sent into therapy or psychiatry for, a cognitive behavioral therapy or some other evidence-based course of care or medication management. And so the outcome of that, like what we're sort of experiencing here is that, first of all, people love it because 96% of the people are getting instant access, right? They're getting direct access to what they need at the time of the need. 90% of members are saying they view the health plan more favorably after going through this experience. So you're just seeing this incredible attachment to what intervention they're being guided to. And then, of course, we can get into sort of the value of this, the outcomes we're delivering in the value-based structure of care that, or of reimbursement that we're, using here.
I mean, it was incredible when we launched the 15,000 users in the first month. I mean, we knew it was going to be successful based on such pent-up need and pent-up demand.
We thought, you never know.
We thought.
Yeah.
That's fair. We thought. We theorized and hypothesized it, yeah. But it was incredible. And importantly, again, because of that triaging that you're talking about, it wasn't 15,000 people who didn't need it. I mean, these are people who end up in programs, need programs, and then a large chunk of these program participants who have moderate to severe symptoms end up substantially down leveling where those symptoms are. It's mild to minimal after the end of their program. And I think it's important to make the point that these people don't want to take meds. Some people couldn't actually access those parts of the system anyway. And so the capacity management you just articulated is incredible. It is major capacity management to really weed out and help someone get past, if it's possible, to get past what's going on in their life at that moment. And I think that was the big surprise for me, is because you think of mental health as sort of therapy goes on and on and on and on and on forever. And this can be a very outcomes-driven condition program, just like diabetes prevention, just like weight management, just like musculoskeletal, all the other things we do. And I have to say, like, we embarked on this with you, and that surprised the heck out of me. And you've said it in a bunch of talks that you've given, like this, there can be, for most of these people, there can be an end to a program and an end to those moderate to severe clinical symptoms. That shocked me.
Yeah. I mean, this, you're touching on one of the numerous paradoxes I think, the mental health care space, which is that you have this huge corpus of people who can't get access to care. And whether for cost reasons or navigating the broken system reasons or availability reasons, whatever it is, they can't get access to it. But there's also a huge body of people who overutilize the mental health system, right? The notion of indefinite therapy, years of therapy sessions, it is rarely appropriate. There are chronic conditions and there are reasons for ongoing care that where that's appropriate. But for the most part, an evidence-based course of therapy in that, call it 6 to 16 week period, should be enough to get someone stepped down into more of a maintenance mode. And that's another really important part of what we're doing here is we're assessing, we're moving people to appropriate care, we're delivering that care and measuring when step down's appropriate. And hopefully at that point, what's happening is they're out of that higher, more acute level of care. We've seen the results. The vast majority are now at a more subclinical level, and they've learned the techniques and the capabilities and still have access to things like the self-care modules, so that if they do need to continue to build a meditation practice or mindfulness practice or healthy sleep habits, whatever it is that they're trying to accomplish, those tools are there for them on an ongoing basis.
I mean, so I thought it took a lot of courage, which you seem to be unflappable talking about this. When I first heard you say that on stage, I remember pulling you aside afterwards and being like, that takes courage to be the one that says no therapy can end. Nobody really talks about the fact that no, there really can be outcomes, but I wonder how much of it, and this is partially speculative, although there's plenty of data to support how effective CBT is. But would you just talk a little bit for 2 minutes, since I didn't in the program intro, about the types of programs Headspace has, mindfulness to cognitive behavioral therapy? Because I think part of what we're saying is, these are very effective from a clinical perspective, effective programs that help a person build the skills and muscle to be able to perhaps permanently change their response to some of the perceived stressors, anxiety inducers, and whatnot. And I think it's partially because you're helping build a skill that lasts for a while.
Yeah, well, I mean, to the point about taking courage, it never, for me, it was sort of just stating the facts that I saw on the ground, right? And I think there's a little bit of, look, if there were 5-10 times more therapy resources out there, if we had all of the professionals and licenses that we needed, then sure, go into therapy forever, right? Like that's fine, right? And if that's something you're enjoying and that's something you're getting a lot out of, that's, I think, appropriate in that case, assuming it's you can afford it. The issue, though, is in a system where you have 6-month wait lists, you've got care providers that aren't all evidence-based. You have 60% of care that's not even, it's cash pay. It's not even covered. When you have a system like that, you have to optimize for the needs. You have to have measurement. You have to have evidence-based delivery of care. You have to make sure that the people who actually have that elevated need are getting the care they need. Because as I think we're increasingly understanding, like chronic condition management, 90% of chronic conditions have a behavioral health comorbidity. So all of these really expensive things, diabetes, MSK, heart disease, ONC, like they all have a behavioral health component. And so if you're really going to solve those cost centers, you have to be thinking about delivering, and those people need often the higher levels of care. They need that higher licensure. So if we're going to get a grasp, it's not even just like, if we're going to get a grasp on the overall healthcare system and get costs under control, behavioral health has to be a critical component to how we're doing that. And so, you asked me a question like 5 minutes ago. Back to the question you asked me. Our philosophy here is, okay, how do we deliver evidence-based, proven care modalities across the spectrum? So how do we start getting people into thinking about their mental health earlier is an important part of this. So programs that we call like brushing your brain kind of programs. So building mindfulness practices, building meditation practices, breathing, the return on investment of just 10 minutes a day of breathing, of doing a little bit of mindfulness and meditation is pretty staggering, right? The reduction in blood pressure, the increase in HRV, the reduction in stress levels. We've seen that you can reduce anxiety at the same level as Lexapro over an 8-week period, just with a daily meditation practice. And so we know this stuff works, and getting people to think about that earlier before they get acute is an important part of sort of, call it population-based management, right? Two then, so we have these programs that allow people to do that. Two then is an evidence-based step care model where we're bringing behavioral health coaches in to solve the vast majority of care, but importantly, they're longitudinal. So as we step someone up into a higher level of care, like let's say they need a therapist now to work on DBT or CBT or something, that coach is staying involved, because what we want is for people to practice in between those therapy sessions. We want them working on the things that they need to work on. That way they graduate as fast as possible. And then you have a trusted resource for step down management. So they get out of therapy, the therapist moves on to the next person who needs it, but now you've got a behavioral health coach who's been with you along that journey. There's trust there. They understand what some of the needs are. And so you can have some check-ins over time to make sure that we don't have the recidivism. You see this a lot in SUD management, right? Where you've got step down care and it keeps people from recidivism. Same concept here, a little lighter weight, but it allows us to manage these things over time and keep costs down, which again, we're bending the cost curve is an important part of the overall model we're trying to implement here.
Yeah, it's building that, again, the addressing the clinical issues, building the muscle to be able to it's not unlike other chronic condition management, to your point, and it's foundational. And one of the things that Russ and I are going to start measuring next together with our businesses is how does participation impact other success in other chronic condition categories. So if someone's participating in both musculoskeletal and pain management program plus, a mindfulness meditation program, does that lead to better outcomes? Or we think in our programs it will. We'll start to measure some of it. We know it's foundational to compliance with medications as well. So, I think Blue Shield of California has done a great job of having the mental and behavioral health offering sit as part of what's called their Wellvolution platform. It's where you find everything you're eligible for. Some payers have considered really kind of separating out, here's all your behavioral health options, here's your mental health options if you need mental health, but to expect someone to know, again, exactly what they need and navigate all of that as a separate thing for their healthcare doesn't make a lot of sense. And we've we've seen this with California and how successful it was, because it wasn't sitting off as a separate platform or separate behavioral health entry point into those benefits. It's sitting there with weight management. It's with musculoskeletal. They're offered many, many things. And that's just one component. It not only reduces stigma, it ensures that we can kind of take a look at holistically what the person needs. And that human being has one entry point to address their need, as opposed to going to different places for it. I think that's really important, and bravo to BSC for doing it that way. Other payers consider doing it differently, which just creates more friction and space between me finding my way to the right solution for me.
You know,
So I think you were going to say something.
yeah, you know, I mean, I think the point's a really important one, you know, to go a little futurist here, right? Like, if you believe that this march towards value-based care, as hard as it's been and how complicated it's been and how maybe delayed we are in getting there, if you believe, though, that we'll get there ultimately, then it's important to recognize how you have to think about these things holistically, right? So in other words, just to use an example, there's no way, if you're capitating reimbursement on, let's say, you know, somebody that's got a heart condition, right? There's no way to maximize outcome and reimbursement there unless you have behavioral health as part of that, right? We know, you know, the data is clear that you need to have behavioral health support in order to deliver outcomes. And that's true for most chronic conditions. I think what you're doing at Solera is so mission critical, because by tying these condition states together and bringing the BH components in as needed, you can really actually start to get to the value-based reimbursement, you know, side of this. And I mean, I know that a lot of the, like, if you talk to health plans writ large, everybody wants to move faster into value-based care, but a lot of it is structural. A lot of it is hard to actually, you know, accomplish. It's hard to actually, like, literally physically make the payment systems work and make the oversight work and everything else that they need to do regulatorily and internally in order to accomplish that. And so bringing the systems together like you do, I think enables a lot of this. At least I think that's why we were able to do this in, you know, a relatively quick time frame compared to how hard it might have been, you know, to pull these structures together otherwise.
Look, I totally agree, and it makes it a much easier sale to a payer to say, look, we are getting paid on a performance basis. Yes, even in the mental and behavioral health space. And I think over the next year, as the economy gets tougher and tougher, and, you know, there's a lot of point solutions out there who are asking to be paid in a way that payers really don't look favorably on. And so our infrastructure, I appreciate you saying that, because our infrastructure that makes it possible to do that kind of value-based payment really, I think, is important for the payer, because that's how they want to do things. But it's also important for the point solution to be able to say, no, it proves that it works, because you're putting your money where your mouth is, as I said in the beginning. You know, I think the other point to make is that you said this in the beginning, you know, 92% of engaged users were more favorable to their health plan once they came into this program and it was offered. And 3/4 of members said they're more likely to engage in other programs. It all goes to what we're talking about here. If this is really foundational and we can use a program like this to get people engaged in their own health, there's all sorts of other benefits. There's other benefits to the payer just from offering it. The NPS scores go up. People like that the payer is offering something that is relevant to them, that's needed, that's convenient, and addressing an issue that's important to them. but they're also more likely to get into some of these other programs. So if you need them engaged in a musculoskeletal program or PT at home program or whatever it might be, in a weight management program, this is really foundational. And so you don't even necessarily have to believe all of the evidence out there to say these programs alone are really, really effective. Mindfulness is not woo-woo anymore. It's incredibly effective. Everybody knows it. There's no debate. CBT, digital CBT, is shown to be very, very effective. This stuff works, but I don't think we've even gotten close to quantifying that follow-on effect of what it does to pair it, with other things. And so I'm excited to look at that together. And again, payers are really interested in, and what we've seen from our payer partners together is they really like the fact that they can offer something that changes their relationship with the consumer. It fundamentally changes their relationship with their consumer in a way that, they haven't really had high NPS scores before. They haven't been looked at that favorably, let's be honest, by the consumer, right? They're not the most trusted party in healthcare. And this creates a mechanism that really facilitates a stronger relationship with the member.
Totally. Well, I mean, you and I, as we have done before, could probably keep talking forever.
Yeah. Should we take questions?
yeah, exactly. But maybe we should see if there are any questions. I know, Jeff, you're around somewhere keeping track of this, and we can try to address some thoughts that the audience might have here.
I am, Russ. Thanks. So one of the questions that we got touched on both quality and value-based care, knowing that one pretty much proceeds into the other. So we've talked about value-based care. Can we talk a little bit about and share how we're measuring the quality of the services that we delivered? And maybe if it's even possible to talk about it within the different modalities, but please take that how you'd like.
Yeah, Russ, do you want to take that?
Sure. So today we are largely focused on standard measures, which, we found is just important to be able to compare across, both what we're doing and others that are out there that are measuring this. So we're using improvements in PHQ for depression. We're using improvements in GAD for anxiety. We're using PSS, perceived stress score, as subclinical measures. And over time, our goal is to improve, in particular, some of those subclinical measures, to make them more granular, because I think PHQ and GAD can be a little harder to move subclinically than it is at a clinical level. But right now, just using standard of care and basically taking ownership over the levels of improvement. So we want to see at least a partial symptom response in order to get a value-based payment or value-based bonus payment in terms of how we get reimbursed.
Yeah, and Solaris sets up, in any of our condition categories, we set up what we refer to as term of art called milestones. And there are a series of clinically relevant activities that must take place, and or outcomes that must take place in order for that to count as a milestone. And if it counts as a milestone, we are filing a claim at that point. So that's when we refer to value-based payment and pay for performance. That's how that payment structure is set up. So somebody may move through partially, not move through to the very end outcome of the program, and then you're not going to be actually getting payment for not moving through to the final milestone or the final outcome. So that's kind of how we set up our payment structure, so that you really require a person to move through those really important clinical gates that we set up in partnership with our point solution partners. And those are all, as Russ said, that's all tied to, clinical literature, whatever the standard of care is in each condition category.
Thank you for that. Another question that was posted, and really it centers on how the treatment levels are determined. And so we know that with our model, folks are first going to be connected with that behavioral health coach. But could you talk a little bit about how treatment plans are identified, the correct provider is identified, And how often does it go? Does it go all the way to the top? How often are we able to keep people in the coaching ranks? But really with the sensitivity around how that decision is made and when it's time to pass off to other care level providers.
Mhm. Do you want me to start that and then
Sure. And
you
then
want to take that? Yeah. So I probably gave a more general version of this in the beginning, but we ask a certain level of questions that I think I mentioned at the beginning with Blue Shield of California. It was 16 questions. And we've got AI that's based on this clinical assessment that we take someone through. So we're asking them questions about anxiety. We're asking them questions about depression levels or that would indicate anxiety and depression levels. We're asking them about perceived stress levels. And then we create a Solera clinical score, and we sort that based on their clinical severity. We're also, as I said in the beginning, though, looking at their motivations and whether we think they're going to do better in a very structured versus unstructured program. But that gives us a really clinically robust look at where the person should be matched and into what level they should be matched. And again, if someone is not appropriate for the programs we're offering, we're working with the payer partner to escalate them into another option. And so we're very cognizant of that. I'd say very conservative about how we deal with that, but we're also watching along the way. Importantly, it's not just about where they're going into, right? So we're watching them along the way and assessing, did those clinical symptoms become subclinical by the end of their program, or do they need something else? And then we're going to help them get to something else, because some of them, a large percentage of them just drop into mild or minimal no symptoms, which is great. Some of them may need some ongoing mindfulness therapy. Some of them may be in what is a very normal third or so of people who need something else. And that's what we're going to help them get to if that's the case. So we watch them longitudinally.
And what I would add is, so as we designed this program, it was really important, obviously, that upfront assessment and the data we're collecting upfront was robust to make sure they're getting to the right place as a starting point. Once they come into our system, we then are using all kinds of technology and clinical oversight. So we are monitoring, and we're using our machine learning capabilities based on the sort of millions of people we've seen in the past to make sure that someone is progressing as we'd expect them to progress. We have automated flags that will help guide escalation if needed, whether it be because of more acute needs, whether because of suicidal ideation or others that will flag to make sure they're getting the right appropriate levels of care. To Mary's point, at some disqualification reasons, we might then refer them back into an inpatient or in-person kind of a modality. But for the most part, we're moving them within our system based on our understanding of what we've seen in the past, based on the live coach and therapist understanding of what the need might be. And that is determining both step up and step down based on, how somebody's scoring and how they're doing over time.
Mm-hmm.
We're doing great on time, and we're getting some really good questions here. A question about some takeaways from the health conference back in November. What did you pick up on, industry wide? And I know you could go in 1,000 directions on this because there were literally thousands of people there. But what do you see the industry steering towards, or maybe even away from? And one of the examples was given was paying for positive end outcomes versus just participation.
I mean, it feels like 4 years ago because it was last year, and I get tired just thinking about that conference.
Dog years, healthcare years
rubbing your eyes.
like dog years.
You're rubbing your eyes like, please don't take me by there. So I think just from a general perspective and specifically to this space, look, outcomes, the economy is getting softer. Payer trend is going up and in a direction that does not feel comfortable to payers or employers at all. And that's projected to continue for the next 3 years or so. And that's partially because of overutilization. It's partially because of really poor health habits. And so I think that, all of that is going to come together and really force all of us who want to work with payers and employers to prove it more, to prove it from an outcomes perspective, to prove it from a total cost of care perspective, to be flexible in the payment models that we do together that work for both parties. And then I think at the same time, there's a recognition that, which is wonderful because I've worked my whole career on this. There's a recognition that the digital and community-based providers are here to stay. This is not going away. Consumers expect access to it. Consumers expect it to be paid for and covered, not just access to it. Consumers expect it to be easier than it is today. I mean, I always say when I'm giving speeches, like my kid can, like one click, and order 34 pairs of shoes, which she did once from Amazon, yet it's so hard to navigate all of this stuff. And so I think there's a lot of themes of paying for outcomes, total cost of care continue to be important, but also streamlining all of this Wild West. I mean, that conference was a great example of like, holy cow, there's so much out here, and which is great. There's so much innovation. There's so much going on. There is a need to streamline and integrate all of this into the rest of the healthcare system and to make this, again, I said in the beginning, a really legitimate part of the healthcare system, a legitimate site of care that is measured the same way we expect other providers to be measured, that has to prove that it works in the same way that other providers have to prove that what they're doing is effective. And I think that pressure is going to continue, which is good for both of us. But
Yeah.
Right, Russ? This is good.
Yeah. So I think one of the things, it's a great question. One of the takeaways for every year, I mean, I've been doing this now for less time than others, but like every year for the last 5 years, next year has been the year of value-based reimbursement, right?
Right, but it's so hard.
But it's right, but it's very difficult. But I think there are three things that is making it more true than ever. One is, it's kind of like the 4-minute mile, right? Like it was impossible until somebody did it, and then everybody started doing it. So I think we're at the 4-minute mile here. I think, like, again, back to why I'm excited about having this conversation today. We just proved it over the last year that this is doable. So, others are going to see, hey, we can do this. It's been done. Like, let's figure out how they did it, and then let's do our own version of it, or, have them help us do it. Two is the economic cycle we're moving into, or are well into. There's more incentives to be very focused on value, right? There's more incentives to make sure you're getting value for the dollar that you're spending. And so I actually think downturns are great times to move into this type of new way of thinking of things. Third, then, is just that the studies are starting to come out more broadly now that $1 invested in BH returns more than $1 back in overall cost of care, right? The Evernorth study over 4 years, 500,000 members, is a really powerful study to show that it doesn't take years, as was the party line historically. You actually have in-year return on investment for every dollar spent on BH, and like 3x that investment return in 2 years. And so I think it's just becoming more and more obvious that the investment should be there, it needs to be there, and there's more appetite as you see some of these models working to invest in it moving forward. So that's I'm bullish, and again, I recognize that every single year has been the year of this. So we'll have
the year of value-based care. Yeah, but I think you're totally onto something. Once someone does it, and we say to payers or others, look, this is totally possible. You can actually require this. You can require this And if that point solution or that provider or that company can't hack it, I think this is the beginning of what starts to separate out who really is going to survive in this system and be sustainable. And it'll be some combination of being able to hang in a payment structure that and an outcome structure that's really accountable, mixed with, a platform approach. We're a platform company, you're a platform company. There is massive point solution exhaustion and fatigue out there. And so now the whole world is turning to streamlining. I got to have, you can't just show up and do one thing. And so it's really important that you at Headspace have the ability to escalate people up and down, and that you've got multiple capabilities in one place. That's really critical. I think the other thing, we hear it constantly from the employer groups and from payers that point solution fatigue is at a tipping point. So over the next year, we're going to see, there is demand. They'll either do it themselves, they'll force the payer to solve it for them, or the brokers to step in and solve it for them. And so I think all of this starts to come together in a different way over the next 12 to 24 months, where there's an expectation for outcomes and everything we just said, but also just that streamlining, the requirement that there's real data exchange going on to prove, the role that whatever the point solution is playing in the system. All the pressure is going to go up, and it is partially at least because of the economic downturn. And you're set up perfectly for that because you're proving at Headspace that it works.
Yeah.
So we don't fear that transition at all. Jeff,
we're actually excited about it. I mean,
welcome.
Yeah,
we want to drive it, right?
Yeah, the incentive has to be there. Like you can push a bowler up a hill for only so long, but like it gets way easier when the incentives are aligned. And so I think we welcome a change in how people think about those incentives. Because I do think that, the more scaled platforms, the ones who have proven this, are going to sort of rise, and a lot of the noise goes away during that period.
Yeah, we haven't said this during this webinar, but it's relevant to this point. I just referred to point solution fatigue from the employers and the need to make sure you have these offerings because consumers expect them. But we also referred to Blue Shield of California many times during this conversation. That is a fully insured audience we're working with. Fully insured buyers are looking at outcomes, looking at total cost of care. It's a different consideration, and this works really effectively in a fully insured book of business because of all the savings we've talked about and the outcomes and the way it's set up. So it's important for any payers who are listening to this, that this is not just it's not just an ASO play because your employers are saying we need new and sexy point solutions delivered to our people. Okay, Jeff, you got one more for us? We probably have time for one more.
We do, and I have a feeling that you guys are going to tag team. I'm combining a couple of questions here because they follow a similar vein.
Because we just talk and talk whenever you ask us.
Just give them all the rest.
Yeah. So it's a question about our partnership, and we got two of these. But the first one is, where does our partnership between Headspace Health and Solera Health extend? Maybe often beyond mental health driven issues into substance abuse, eating disorders, et cetera. I think that there's a good payer interest or just general interest in that. But also as we talk about what we might do next, Mary, you touched on earlier about the link between behavioral health, positive mental health, and people to be able to cope with other physically related conditions. Sort of following the line that anytime anybody gets a complicated diagnosis, they've usually got to get things straight up in their head before they're going to be able to tackle that. So a little bit about where do we go next? Do you see us moving into either of these? How could we partner better with health plans to address additional mental and behavioral health issues? And then specifically beyond that, how do we partner more where we can see outcomes at a clinical level on the physical side of health? So I'll let you guys decide who's going to start with answering which on those.
You want to let it rip first?
Sure. I mean, I'll start in. This feels like our quarterly, our QBRs here. It feels like our strategy session. Yeah, I mean, look, first of all, I think that, last year was an incredible year proving out the core model. And so this year, a lot of this year is about scaling it, right? So bringing it to new payers, bringing it to new partners, scaling the work that we're doing with Blue Shield of California. Two is then I think that there's an immense opportunity, as we've talked about a little bit here, not just expansion into other mental health condition states, which we do support and want to continue to expand into more sort of specialty care over time, with partnership here. But I think all chronic condition management and connections to be able to support those members in alignment with those conditions that they're working through. So in as much as they are trying to figure out, okay, how do I solve for my weight problem here? How do I solve for my pre-diabetic condition here? Ensuring that those members are also getting the right level of BH support in we're measuring, the efficacy of these condition states as we, again, move towards value-based care, as we move to the right reimbursement, I think is a really exciting next, this is a years-long pathways, but really exciting next set of steps for us to bring all of these things together and really crack this value-based reimbursement model.
Yeah, agree. I think there's the clinical component, which we're very interested in measuring. So if someone is in Headspace, are they more likely to participate in and succeed in another condition program? So I think that's a really high priority for us to be crossing people into, which we're already doing. We're already crossing people into multiple programs.
Yeah, we need a webinar a year from now.
Yeah,
let's do that, right?
Let's do it. And then we'll measure it, right? But there's also just an engagement thing too, which is, I think we're hypothesizing that if someone just goes through this program, goes through a Headspace program, we know they're more likely to, from asking them the question, we know they're more likely to engage in another program. So again, we're just building the muscle of how to engage in digital programs that are evidence-based, very effective clinically, that are offered and covered by their payers, employers in some cases. And so it's not just clinical, it's just, we're building an engagement muscle that we think makes it easier for them to jump into the next thing they need and work through the next thing they need. And that's an important part of it. This is kind of a new landscape for the consumer, and we're trying to make it really, really easy for them to get engaged and stay engaged. And that benefits everybody when that happens.
Well, thank you both for your time today. We really appreciate this. I do want to say to all of our attendees that we will be providing a recording of today's webcast for you. And also there's a couple of questions and some sub questions that we didn't fully get. And we wanted to let you know that we will be reaching out to you directly on those. So thank you all so much. We hope that you have a good rest of your day and a very good upcoming weekend. Thanks, everyone.
Thanks, Jeff. Thanks, Russ. Bye.
Always a pleasure. Always a pleasure. Thank you.
Bye, everybody.